Hello everyone and welcome to our module on skin cancer. Shown on this slide are the layers of the epidermis, and I discussed these layers in more detail in the video on the skin. But what I want to point out to you here is that the three common types of skin cancer all arise from some cell found in the epidermis. Most of the cells in the epidermis are squamous epithelial cells called keratinocytes, so if one of those cells begins to grow uncontrollably, that leads to the malignancy squamous cell carcinoma. The basal layer of the epidermis is the stratum basale. This layer contains stem cells which are always dividing to replace lost keratinocytes. So because these cells are always dividing, you can imagine that from time to time one of them will begin dividing too much and uncontrollably, and that leads to basal cell carcinoma, which is the most common type of skin cancer. And then finally, not shown on this slide are melanocytes, which synthesize melanin. They're found in the bottom layers of the epidermis, and if one of those becomes malignant, that leads to melanoma. Let's start by talking about a skin lesion called an actinic keratosis. It's also sometimes called a solar keratosis. These are pre-malignant skin lesions, and they're caused by sun exposure. That's why they're sometimes called a solar keratosis. Sun exposure leads to growth of atypical epidermal keratinocytes, and that's what leads to an actinic keratosis. I'll show you a picture of what this looks like in a minute. But anytime you see a patient who has one of these skin lesions, you should be aware that this lesion is pre-malignant, and it can eventually become a squamous cell carcinoma. As there's more and more dysplasia present in the actinic keratosis, eventually this can turn into a squamous cell carcinoma malignancy. Actinic keratoses are round red-brown papules or plaques. They occur in sun-exposed areas. This is a picture of one on this man's head right here. There's also a picture of one on the ear in this patient right here. The best way to learn what these looks like is to Google them and click on images and look at about 10 different images, and you'll get the idea. If you biopsy one of these actinic keratoses, what you will see is first of all hyperkeratosis, which is increased thickening of the stratum corneum, the outer layer of the skin, and you also see epidermal cell dysplasia. Remember, dysplasia is the hallmark of this pre-malignant lesion. In addition, you will see parakeratosis. It's high yield to know this. Parakeratosis is retained nuclei in the stratum corneum. Normally, the keratinocytes in the stratum corneum have lost their nucleus. They are anucleated. But in this disorder, because there's dysplastic cell growth, you will see parakeratosis, which means there will still be nuclei present in cells in the stratum corneum. So that's a nice segue into squamous cell carcinoma, which is the type of skin cancer that can evolve from an actinic keratosis. This is the second most common type of skin cancer. Basal cell is the most common. We'll talk about that later. And this type of skin cancer arises from squamous cells in the epidermis, as the name implies. It occurs in sun-exposed areas, so it's often found on the face. Sometimes it occurs in the lips. It can occur in the ear and sometimes on the hands and other parts of the body that are exposed to the sun. The reason it occurs in sun-exposed areas is because there is DNA damage caused by UV light when the sun hits our skin. This also tends to occur in older patients. It's very rare in people under 45, and it's very common in people over 75. In general, this is a relatively benign form of cancer. Less than 5% of all squamous cell carcinomas will metastasize to regional lymph nodes, and it's very rare to metastasize beyond the nodes. One of the biggest problems with these lesions is that they often occur on the face, and they can be disfiguring, and the surgery to remove the lesion from the face to prevent growth and spread often causes more disfiguration. These lesions tend to be red and scaling with sharp borders. So this is a picture of one shown here at the bottom left side of the screen. Notice the sharp borders. Notice that it is red. As the lesions get more advanced, they can ulcerate and produce keratin. This can lead to a deep pit, like shown on the left side of the screen. You can also see it on this man's nose here. There is an ulcer in the middle of the lesion, and it's thickened from keratin production. These lesions can also crust or bleed. There's some crusting on the nose of this man whose lesion is shown on the right side of the screen. Once again, Google squamous cell carcinoma of the skin and look at about 10 pictures, and you'll get the idea of what these look like. Risk factors for squamous cell carcinoma are shown on this slide. First of all, sun exposure is obviously a risk factor. Second is chronic immunosuppression. So our immune system is very important in detecting and destroying abnormal squamous cells in the skin. So if you're immunosuppressed, you're more likely to get squamous cell carcinoma. So this occurs in patients who've had an organ transplant and take immunosuppressive drugs. It can be seen in patients with HIV, and it can be seen among patients who are taking long-term glucocorticoids for immune suppression. If you have any cause of chronic skin inflammation, this can potentially lead to squamous cell carcinoma. So when the skin is inflamed, new squamous cells are being produced, and squamous cells are triggered to grow, and this can lead to squamous cell carcinoma. So patients who have had burns have damage to the skin and chronic inflammation. Patients who have a chronic skin ulcer that won't heal have inflammation at the edges of that ulcer, and that can lead to squamous cell carcinoma. And then some patients have an infection, for example, in the abdomen or in the bone, that develops a sinus, which means a connection to the skin. And sometimes these will chronically drain, and they're very difficult to heal. So over time, that skin surrounding the sinus tract can develop into squamous cell carcinoma. And then finally, arsenic exposure is a risk factor for squamous cell carcinoma. This is found in contaminated drinking water. So there have been some famous cases where people in a certain town or certain area of the globe were drinking contaminated drinking water, and the rate and incidence of squamous cell carcinoma became very high. The classic finding on biopsy of a squamous cell carcinoma is the presence of keratin pearls. There are a couple of them shown in this image on the slide here. Once you've seen them once, they're very easy to recognize, and just remember this as the hallmark pathologic finding. Keratoacanthoma is a variant of squamous cell carcinoma. It's sometimes described in textbooks as a squamoproliferative tumor, which is a fancy way of saying it's a variant of squamous cell carcinoma. These are usually benign and they usually resolve on their own, but you need to know that they're a variant of squamous cell carcinoma. They appear as a dome-shaped nodule with central hyperkeratosis. This is a picture of one on the screen here. So you can see that it looks like a dome. It's a raised nodule, and in the center there's this thickened area, and that's caused by hyperkeratosis. A classic feature of this variant of squamous cell carcinoma is that it grows rapidly, so it will develop over just a few weeks, and then if you leave it alone, it will often regress over time. These are usually removed surgically or followed over time for regression. Bowen's disease is the name given to squamous cell carcinoma in situ, meaning squamous cell carcinoma that has not yet broken through the basement membrane and invaded the dermis. It presents as a well-demarcated scaly patch or plaque. This is a picture of Bowen's disease on the screen here, and once again, go look at some images online and you'll get the idea of what this typically looks like. Now let's talk about basal cell carcinoma. This is the most common form of skin cancer, and that's because basal cells are always dividing in the epidermis. So naturally, once in a while, one of them will begin dividing in an uncontrolled manner, and that can lead to the presence of a basal cell carcinoma. These are generally slow-growing tumors that rarely metastasize. They are usually benign. Most are found early and excised. And just like squamous cell carcinoma, they occur in sun-exposed areas. And also just like squamous cell carcinoma, one of the major problems is the cosmetic features. These can occur on the face, and the lesion itself can damage the skin and be disfiguring, and also the scar that's left behind after they have been excised. Of the three types of skin cancer, basal cells have the lowest potential for recurrence or metastases. Basal cells are the least likely to recur or metastasize, melanomas are the most likely, and squamous cell carcinomas are in the middle. The classic description of a basal cell carcinoma is a pearly papule or nodule. If you look at this picture at the bottom right side of the screen here, you can see that the basal cell carcinoma just has a shiny or pearly appearance. In addition, they often have telangiectasias on the surface. These are dilated blood vessels. If you look at this picture on the bottom right, you can see some of these blood vessels here. They sometimes will ulcerate in the center, and they can develop a crust. This person has one on his nose. You can once again see that it's pearly out here, but it's got a little bit of crust there. And sometimes the borders can be rolled, which means rounded or thickened. There's a picture of that at the top right side of the screen here. You can look at these rolled or rounded borders. But in all of these lesions, the key feature is the shiny or pearly feature, especially in a Step 1 board question. That's always going to be the way they describe a basal cell carcinoma. The hallmark on biopsy of one of these lesions is to see nests of basaloid dark cells in the dermis. This is a picture of what it looks like right here. Big patches or nests of dark basal cells. In addition, if you zoom in on some of those nests of basal cells, you will see what's known as palisading nuclei. This is the term used to describe cells at the periphery of the nest where the nuclei line up in parallel. If you look here, the nuclei of all these cells are sort of lining up one beside each other. That's called palisading nuclei, and that's something that's seen in basal cell carcinoma. Superficial basal cell carcinoma is a special variant of basal cell carcinoma. It accounts for about 30% of these skin tumors. It presents as a light red to pink plaque with a little bit of scale, usually on the trunk. This is a picture of one right here. So it's very hard to identify this just from looking at it, especially at the med student level. This looks like a lot of other skin lesions, psoriasis, some other skin disorders. You should just be aware that there is a variant of basal cell carcinoma that looks like this. In a board question, they would likely show you or describe this lesion and then give you some other clues that it actually represents a skin cancer. You don't need to know a lot about the treatment for squamous cell and basal cell carcinoma of the skin, but I'll just briefly highlight on this slide a few of the ways these tumors are treated. First of all, they can be surgically excised. In some cases, cryotherapy is used, which means to use cold to try and make the lesion fall off. You can also use electrosurgery and radiation therapy, and there are topical chemotherapy agents that are used in some cases. In some cases, low-risk lesions are left alone, but the high-risk lesions, which are thought to have the most likelihood of spreading, those are often excised. So these tend to be larger lesions or a lesion that has recurred after an original lesion regressed or was excised. Some lesions in specific locations are known to be very likely to recur or metastasize. And then finally, especially for squamous cell carcinoma, when it occurs in an immunosuppressed patient, that's usually considered a high-risk lesion, and that usually is surgically excised. We'll finish this module by talking about melanoma, which is a highly malignant form of skin cancer, much more malignant and dangerous compared to squamous cell and basal cell carcinomas. The way you can recognize a melanoma is traditionally taught by remembering A, B, C, D, E. So the A is for asymmetrical. So if you look at this melanoma on the screen, you can see if you cut it in half, the left half is different from the right. It is not symmetrical, it is asymmetrical. In addition, the borders tend to be irregular, so you can see that these are not nice, smooth, rounded borders. It is sort of bumpy and irregular. There's color variation. Notice how some parts of the lesion are very dark and some parts are light brown. The diameter is usually over 6 millimeters, and then finally the E is for the fact that they evolve over time. So if you examine a lesion and you think it might be a melanoma and you examine it a few months later, it will be evolving and changing, and that is different than other types of skin lesions that can mimic melanoma, things like a nevus. There are a couple of subtypes of melanoma, so let's talk about that now. The superficial spreading subtype is the most common subtype. This is the subtype we talked about on the last slide that can be identified by the A, B, C, D, E findings, and this is responsible for about 75% of melanomas. And this subtype gets its name because initially it is superficial and tends to spread radially, meaning out to the sides, not down into the body. We'll talk more about that in a minute. The second subtype is called nodular. This is responsible for about 15 to 30% of melanomas. It looks like this example shown on the screen here. It's a dark nodule raised above the skin. This is a very aggressive subtype of melanoma, and the reason it's aggressive is because instead of growing radially, like the superficial spreading type, it grows vertically, meaning up and down. Because it grows up, that's why it forms a nodule, and because it grows down, it quickly invades the dermis and often metastasizes. Because this is such an aggressive subtype, it's responsible for 50% of melanoma deaths, even though it's only responsible for about 15 to 30% of all melanomas. Lentigo maligna is another subtype of melanoma. So the word lentigo means a small, flat, dark spot on the skin, basically a large freckle, and many patients have lentigos present on their body in adulthood. But a lentigo is confined to the epidermis. A lentigo maligna is a lentigo that begins to grow. It's still confined to the epidermis, but it starts to expand. This is sometimes called a melanoma in situ because that's basically what it is. It's a collection of cells with lots of melanocytes inside of the growth. A lentigo maligna melanoma is one of these lentigo malignas that has now invaded the dermis. These are very slow growing. They take years to develop, and over those years they spread and darken and become lumpy. And for that reason, because it takes years for these to develop, usually a lentigo maligna melanoma is going to be seen in an elderly person. That person will say, I always had a dark freckle, a large freckle, something like shown on the screen here on my skin, but over time it's begun to darken and grow, and then on biopsy it will be shown to be invading the dermis. That is a lentigo maligna melanoma. The last type of melanoma is called acral lentiginous. This is the least common type of melanoma. It accounts for less than 5% of melanomas. And the word acral means related to the extremities, so these melanomas are found on the palms, on the bottom of the feet, or under the toenails or fingernails. And what you need to know about this type of melanoma, even though it's not very common, it's the most common type in dark-skinned patients. So in particular, patients who are Asian or African American, they have darker skin. And most melanomas and most skin cancers in general are more common in lighter-skinned individuals, people that tend to sunburn more easily. This rare type of melanoma is an exception in that dark-skinned patients tend to get it more commonly than anyone else. Some risk factors for melanoma are shown on this slide. First of all, sun exposure, especially severe sunburns in childhood. Unfortunately, most of us who get sunburned have it happen when we're children and we're playing out on the beach without sunscreen on. But nevertheless, if you have experienced a severe sunburn in childhood, that raises your risk of developing melanoma. Another risk factor is the presence of nevi or moles. This is a picture of a mole or a nevus on the screen here. And a third of melanomas arise from dysplastic nevi. So a person will have one of these moles on their skin. It will be exposed to sun over time, and then at some point in their life, the mole will develop dysplastic features, and that can turn into a melanoma. So the more nevi you have on your skin, and some people have lots of moles in their skin, the more melanoma risk you have, because one of those nevi can potentially become a melanoma. And then finally, your skin type is associated with melanoma risk. People who have very light sensitive skin are at increased risk for melanoma. So these are people who have light skin pigmentation, people with lots of freckles, and people who have poor tanning ability. You may be like this, or you may know someone who always sunburns when they go out in the sun. They rarely ever develop a suntan. Those are people with light sensitive skin, and those people are at higher risk for melanoma. The diagnosis of melanoma is made through a biopsy. There's really no single diagnostic feature of these tumors when you examine them under the microscope. What you see are nests of melanocytes. Many of the cells are atypical with irregularly shaped nuclei. What they will want you to know for step 1 of your boards is that a classic tumor marker for melanoma is S100. S100 is a calcium binding protein found in the nucleus of melanoma tumors. It's very sensitive, meaning that S100 is present on the majority of melanomas, but it has a low specificity because S100 is found in other types of tumors. Let's talk about treatment and prognosis. So usually melanomas initially grow radially, which means they spread outward along the epidermis and upper dermis. At some point they shift into a vertical growth phase where the tumor cells invade downward into the dermis, and this is where they can metastasize and become deadly. So if you know this, then it's very easy to appreciate that the more depth there is to the tumor, the more the risk of metastasis. And there is a standard metric called the Breslow thickness. This is the distance on a biopsy from the granular layer of the epidermis to the deepest tumor cells, and the greater the Breslow thickness, the more likelihood of metastases. The treatment of melanoma is excision with wide margins, and the wide margins are very important. This is a highly malignant tumor, and if you leave malignant melanocytes behind, they may metastasize and appear later in some other part of the body. Melanoma can metastasize either through the blood or the lymphatic system. It tends to go to the lungs, the liver, and the brain, and metastases are the most common cause of death. I once took care of a woman who had had a melanoma removed, and she presented 20 years later with seizure. She had a lesion in her brain, and that lesion was melanoma. One or a few cells have been left behind on her skin, and those cells eventually caused her death. That's how dangerous this tumor can be. Let's talk briefly about some of the genetics associated with melanoma. About 50% of sporadic melanomas are associated with a mutation in the BRAF gene. BRAF gene is a proto-oncogene. Its normal role is to trigger cell proliferation when it is activated by a protein called RAS. We'll talk about how that works in a minute. About 90% of the melanomas with a BRAF mutation have a specific mutation called the V600E mutation. And among tumors that have the V600E mutation, those can potentially be treated with drugs that are BRAF inhibitors. The two drugs that do this are vemurafenib and dabrafenib, and both of them inhibit BRAF and have been shown to increase survival in patients who have a melanoma with the V600E mutation. Here's a picture to help you understand how the BRAF gene product works. So when a growth factor encounters a tyrosine kinase receptor in a melanocyte, that can activate the RAS protein. RAS can interact with the BRAF protein, and that leads to cell proliferation. RAS also interacts with a protein called PI3K, which can lead to cell survival. Normally, this is a very tightly controlled process, but in patients with melanoma, they have a mutated BRAF protein that leads to uncontrolled cell proliferation. So if you administer a drug that inhibits BRAF, that can shut down this cell proliferation, and that improves outcomes in patients who have these types of mutations present in their melanoma tumors. And that concludes our video on skin cancer.